Good morning, everybody. Let's see if I can figure how this proceeds. Okay, so as Dr. Hopkins just said, I'm originally Italian. I'm a new face. I'd like to introduce myself at these big meetings. I had the pleasure of presenting something last year, but because of COVID, I did not meet anybody in person, which was a pity. So a little bit about me, just because we know much about you, and I think it's important for you to know a little bit about me as well. I'm originally Italian, so I come from the great city of Milan. We are currently the soccer champion in my country, which is a pretty big deal. And we also have what I consider one of the best pizza in the country and the best lasagna. I did my med school there. I started cardiology in there. And then I went north, went to Switzerland. And the reason why I went to Switzerland is that because they have a fantastic ARVD program there, long friends of the Hopkins program, but also because they have fantastic chocolate. And that's how they recruited me. And they really, I stayed there for a year. Then my blood sugar was getting a little too high. So they offered me to fly across the big pond and come to Baltimore. I arrived in 2020, joined the Hopkins team since, and I was exposed to crab cakes. And I have enjoyed the Hopkins registry and the Hopkins team immensely. Unfortunately, I've also discovered I'm deadly allergic to crab cakes. So the scientific performance is going great. I'm still figuring out my way around food in here. So it's dangerous. Please don't feed me crab cakes if you see me wandering around. Jokes aside, my topic today is desmoplakin. So what's desmoplakin? Desmoplakin is one of the many desmosomal genes. And for us, it's really important because while PKP2, plakophilin-2, is the most commonly associated with ARVD and arrhythmogenic cardiomyopathy, the second most common gene that we find these days is probably desmoplakin. And over the last few years, probably since 2015, we have seen a big rise in the number of patients that comes in with a variant in the desmoplakin gene. And as many unfortunately know, while our diagnostic criteria worked very well for the right dominant forms of disease, so the classical ARVD, we were not great at diagnosing DSP-associated cardiomyopathy over the years because the criteria we do have do not work very well for the left-sided. And so there has been a little bit of overlook of this form, and we have been focusing on this extensively over the past few years. And there is a short on my list of why addressing desmoplakin today really matters. We do not have a ton of evidence on this. We are building on this. We don't know if, or at least there is not a lot of data showing how severe in terms of arrhythmic phenotype desmoplakin variants are. We know that they do tend to lead to a distinct disease phenotype, something that we will call ALVC probably because of the left-sided involvement. And we also know that this disease is associated with something we call myocarditis, so bouts of inflammation at the level of the heart that generally can present with chest pain, something that will be uncommon for classical ARVD. And we don't exactly know what's the role of exercise in disease progression and in arrhythmia insurgence in desmoplakin compared to the more classical right-sided disease. And as mentioned, most of our data come from heavily plakophilin-rich or gene-negative rich cohorts. So it's really important for us to address desmoplakin as a sort of a distinct entity just because we want to treat each patient individually. We really believe in gene-tailored and patient-specific management. And so we're trying to gather as much data as possible to provide each individual with their own answer and not just to throw out umbrella definition that may not satisfy anybody. One of my favorite quotes is from Mark Twain. It says there are like lies, bad lies, and statistics. We believe in statistics here, but we also want to address each patient individually. And that's why we're really been focusing a lot. This is just to show a little bit about what's been published on desmoplakin over the last few years. There is not a lot of literature. This is a sort of a very frontier topic in terms of research for us. There is a couple of papers on the right, that's the Hopkins experience. On the left, there is a collaboration coming out of Michigan and Boston. There are some European colleagues of ours that have published a little bit. But if you add up the numbers down there, you will see that the amount of patients phenotyped and characterized over the last 5 years, we are talking less than 200 patients across the world. So it's not a lot of data, and we are actively working on that. And so since I arrived here working with Cindy, working with Dr. Hopkins, we have started something that we decided to call the Desmoplakin Network, which is a gene-specific effort to work with patients with DSP variants. And we started in fall 2020 as a worldwide effort. We have contacted all the colleagues across the world to work with us and start gathering data to provide robust gene-specific data for patients harboring DSP variants. Just to give you a sense of who's involved, we really reached out to the most important center across the world. We tried to be as inclusive as possible. All the colleagues in America, in Europe, and in Australia have been involved. And we have been including patients presenting alive for which follow-up data is available with desmoplakin pathogenic or likely pathogenic variants. Brittany has been reviewing all those data, so she has been a paramount importance for this project, very committed to this. And we got a great response, just to show how much of an interest we have at a patient level. Patients, we work with some patient advocacy groups, especially in Germany, to get more data, but also from our colleagues, because there is not a lot of data out there, and we really want to know how to best treat all of you and these patients. And we got data from more than 800 patients, which is the largest collection of desmoplakin ever to be performed. And the data I'm going to show you today is just some of the preliminary data we have retrieved from this analysis. So, going back to the first questions that I presented, arrhythmogenicity. What do we know about desmoplakin? Desmoplakin variant carriers seems to have a high risk of arrhythmias, regardless of the phenotype. What I mean by that is that, so with 2010 task force criteria, the diagnostic criteria you heard referred multiple times today, don't seem to work perfectly in desmoplakin. For some patients work. We do have ARVC patient with desmoplakin variants. And those patients have a relatively high risk of arrhythmias, around 8% per year, which is fairly high, fairly consistent. But even for those patients that do not fulfill task force criteria, we have around a 4% per year risk of arrhythmias. Now, not all those arrhythmias are, fortunately, leading to bad outcomes. There are many stable arrhythmias, but nonetheless, those are arrhythmic events that are important. And this data really shows that we need to characterize those patients in depth, and we should not overlook them because there is a significant risk of arrhythmias. Now, there were some talks about considering desmoplakin as a low risk. This is probably more scientific and a research statement more than anything else, but our data clearly shows that even if in Europe, for example, the recent guidelines did not consider desmoplakin as a high-risk gene, that's not the case. Unfortunately, we're seeing plenty of events, and we really need to take care of patients with desmoplakin as if they were at a high risk of arrhythmias. And something really important and peculiar for us is that while right-sided ARVC, PKP2-based ARVC, seem to have more arrhythmias in male patients, we are seeing the absolute opposite in desmoplakin cardiomyopathy, with female patients being affected more often and having a higher risk of arrhythmias. This was a sort of a shocker for us. We did not expect this, but it seems to be the case, and it's not just us seeing this. In all the registries involved, we're seeing more female presenting with DSP variants and female patients having poorer arrhythmic outcomes, unfortunately. So it's really important for us to pay attention to those that are specific feature of this disease. We don't want to use umbrella features. Not all arrhythmogenic cardiomyopathy are equal, and it's really important for us to pay specific attention to this. This is why Dr. Hopkins today was saying that we are moving towards a more gene-tailored approach for diagnosis and management, because that's what really matters. We are seeing differences, and we really want to value those differences in clinical care. Second point, as mentioned, this disease has a distinct phenotype. It's not like the rest of arrhythmogenic cardiomyopathy. We're seeing a left side involvement very, very frequently. 80% of patients with a 2010 task force phenotype will have a left side involvement. Even patients without a task force phenotype have fibrosis in the left ventricle at magnetic resonance. So really a distinct subset of patients that will require a different kind of management. And as mentioned, we have a relatively high rate of heart failure and arrhythmic episodes. So something that we should not underlook as a disease. This is just some graphs that come out of the analytical skills of Dr. Carrick that shows is the best at equations and numbers. But for us, this is really important because it means that when we are asking for tests in patients with desmoplakin, we are not looking at those tests using the same thresholds or the same cutoffs we use for all patients. We're really using gene-specific cutoffs, and we use this large consortium of data to derive robust evidence telling us, what's the point of ejection fraction at an ultrasound for which the risk of arrhythmias goes up. The answer, in this case, is 50%. But we're using this data to really have gene-specific, DSP-specific cutoffs. The hope is that in the future, we'll build up a consortium for many other desmosomal genes, and we'll go gene by gene and have risk features in a gene-specific manner for all the genes involved in arrhythmogenic cardiomyopathy. And this is just a graphical representation of those that seem to be the most commonly associated risk feature in desmoplakin cardiomyopathy. Some of those will clearly overlap with the classical ARVD risk, non-sustained ventricular tachycardia. Those PVCs are clearly associated, but the left side involvement is clearly new, and it gives us a lot of clinical insight on how to best approach the management of patients with DSP. And a few final points. As mentioned, we do have seen those myocarditis events in this patient population. Those are not uncommon, around 1% per year. It seems to be the occurrence rate. And this is clearly meaningful for us and for the patients, of course, because we know that after those events, it seems to be sort of a hot phase of disease with an increased risk of heart failure and arrhythmic events immediately after. So to give a sense, the curve on the left, on the right actually, it shows that the blue line is the event rate for patients with no myocarditis events. The red line shows how quickly the disease progresses once that a myocarditis event is unfortunately experienced by the patient. We are currently working on characterizing those events better and to see if we can do something with drugs, with some sort of therapy to reduce this observed risk. As I mentioned, it's a frontier line of research for us, so we do not have the answer today. We hope to have the answer soon. Finally, we're currently studying the role of exercise in pregnancy. We have pretty robust data for classical ARVD forms. We are working extensively on those two for DSP, so many of you may have already been contacted for some survey question or phone interviews regarding your exercise exposure or previous pregnancies. Many will be probably contacted after this seminar, and this data collection and your contribution is really important to us because thanks to those questions we can answer those important questions for all patients and bridge that into clinical practice. Finally, final comment on this. As mentioned, most of the data we have derived from gene-negative and PKP2 risk-sided cohort. So the risk score that was mentioned previously is something that works really well for classical ARVD patients. Does not seem to work exceedingly well in desmoplakin. So currently, we're not using this for desmoplakin patients because it seems to underestimate the risk as they are sort of a different clinical entity. And we are actively working on building a gene-specific risk calculator for this subset of patients. So what are the next goals of this network? We're really working in addressing this in a gene-specific way, both for features and both for risk calculations. We are trying to understand the gender differences in DSP cardiomyopathy. We believe that sex hormones and pregnancy may be strongly correlated with this. We're working on that. We're trying to understand the role of physical exercise. And again, we're trying to assess the rate of disease progression. Thank you for your time.